Welcome back to another episode of the Simplify Senior Transitions podcast. I'm Dale Corpus, a senior transition specialist and real estate expert based in the San Francisco Bay Area. And I'm also part of the sandwich generation, juggling the needs of both aging parents and younger kids, just like many of you. I created this podcast to make senior living transitions less overwhelming for families. Whether you're an adult child helping your parents navigate housing and care decisions, or a senior planning ahead for your own future, this show is for you. We bring in trusted professionals from across the senior care world to answer the questions you didn't even know you had, so you can make confident, informed decisions. Today's episode is all about hospice, and not just what it is, but how it works behind the scenes inside a large healthcare system. My guest today is Jerry Louderback at Sutter Care at Home, one of California's most respected hospice providers. Jerry brings a wealth of experience supporting families during some of life's most vulnerable transitions, and today he's pulling back the curtain on what actually happens when a patient is referred to hospice, how services are coordinated, and why early planning makes all the difference. Whether you're a caregiver, a healthcare professional, or simply exploring what hospice really means for a loved one, this episode is packed with clarity, compassion, and real-world insights. Let's dive in.
Welcome to the Simplify Senior Transitions podcast, where we help families navigate senior living, real estate, and everything in between. Hosted by Senior Transition Specialist Dale Corpus, this show brings you expert insights, real solutions, and stress-free strategies to make senior transitions simple. Ready to dive in? Let's go.
And we're back, everybody. Jerry, welcome to the show today. How are you?
I'm doing great. Thank you for having me. I really appreciate it.
Now, I want to go ahead and just jump into questions. So let's start with your personal path. What drew you into hospice care and eventually Sutter?
Like a lot of folks who are in hospice care, it's not something I intended to do. It's very common. It's a drawing that people have. I know through the years that I've been in hospice, I've hired folks who I was so excited to get. Clinically, they're incredible, but they don't have the it factor for why they're in hospice, because hospice is very much a calling. My personal story is I was in a whole different world, a whole different industry. I had a personal thing happen to me, kind of reshaped what was important to me. I ended up going back to school, and while I was in grad school, one of my professors actually ran a hospice program. Yeah, my grandmother had been on hospice previously, so I was really drawn to it and did a few papers, a lot of conversations and research about hospice and end-of-life care and just care in general for folks. And through that, he actually, upon graduation, asked me if I wanted to come work with him. And I did. And, it was 25 years ago. I didn't think I was going to continue to do that. I thought it was a good foot in the door, blah, blah, blah. And I used to be the young guy in the industry, and now I'm not quite as young.
25 years is quite some time. You definitely experience in this field. So what is your role as a hospice administrator at Sutter Care at Home in Concord, and how does it differ from other hospice roles?
Well, yeah, it's very interesting. Sutter Care at Home is a dynamic organization. We're very large. We have a huge footprint, and we have various lines of service, right? So it's not just hospice, and that makes us unique from other folks. But my role as the administrator really is to put people in position to succeed.
Okay.
One of the things that I always think is so important is that if people are expecting, people meeting patients and their loved ones, if they're expecting something other than what hospice is, we have failed them. And it's hugely important in my role to make sure that our team is in position to provide the best care possible. And we're helping people when they are literally at their most vulnerable.
Yeah.
And it's not just is not a strong word or a good word here, but it's not just for the patient having a passable end-of-life experience, but it's also for the lasting memories that their loved ones have behind about those last days. So my role in one sentence is to put people in position to provide the best care possible.
Nice. Now, Sutter is a major player in California's healthcare landscape. How does Sutter's hospice philosophy connect with its broader mission?
Our mission is caring for our patients first and our people always.
Yeah.
So it's pretty basic, it's pretty simple, but it's beautiful. And the way that Sutter Care at Home is we're very much a piece of that puzzle.
Okay.
So rather than a hospital system that's just a hospital, right? Where there's like, all right, just kick them out and we don't want them back in here. Right.
Now,
That's the typical model. Or the doctor, a private practice doctor who just has an office, who his role is, oh, I don't want to talk about end of life care options for folks because I'm not comfortable doing that. Or a skilled nursing chain who's got their own dynamics, right? Rather than all of that, we are an all-encompassing health care provider. And so Sutter Care at Home and the hospice program, which I represent, are very much a continuum of the care that people get. That makes us very unique because we have training that is deeper than a lot of other providers. We're able to take more complicated cases than other providers, and we don't bat an eye doing it. We're able to provide care in multiple locations and all 4 levels of hospice care.
okay, nice. Now, what's one thing about working with a healthcare system that families might not realize impacts hospice care?
That's a really interesting question because families probably aren't going to know the difference unless they've had a family member on another hospice previously.
Mm-hmm.
Because for most folks, it's kind of learning as you go. And it's not uncommon. Maybe they had an aunt or an uncle or a grandparent who had been on hospice, but they hadn't been in that direct line of being on hospice. For those who have experienced it before, and it really goes back to what I talked about a moment ago, it's the continuum of care. It's the ability to really transition patients, meet them where they are, and provide them what can be complicated cases, or sometimes they think they need a lot of complicated interventions. And as we work with them and we help them understand what we do and we understand what their needs are, we're able to hopefully simplify their care so that they're able to live the best that their body is allowing.
Yeah. Okay. One question for clarification purposes for folks that are new to hospice. Sometimes people think that hospice is a place that you physically go to, right? Can you dispel that myth?
It's not. Yep. Hospice is a philosophy of care.
Yeah. Yeah.
And so you asked earlier about my role as administrator and what I do. One of the things that I've done in my previous roles is actually educate patients and families right at the beginning of hospice about what we do. And one of the things that I always said, oh, there's a red flag here. So I'd get how many hours a day, blah, blah, blah.
Yeah.
And, that's not what hospice is. So hospice goes where a patient lives.
Yeah.
And sometimes it's folks who live at home. That's the most common. A lot of patients live in a skilled nursing facility, an assisted living facility. We have patients, short term, I want to say this qualified, short term, it's one of the levels of care that Sutter could actually do in one of our Sutter hospitals. And that's short term, and it's a crisis situation, but it is something that we can do. So it is not a place that people go to. So that's the message hopefully people will hear.
Okay, perfect. Now, I want to segue into questions about how hospice works behind the scenes. First question here is, walk us through what happens logistically after a hospice referral is made. How quickly do things move?
Yeah, as quickly as they need to, right? So
Yeah.
I was looking at a report last night, as a matter of fact, and we had one patient who was referred to us, and it was 372 days before they actually started hospice.
Okay.
Right. And that's crazy.
Wow.
It basically means that something was going on, and it could have been a situation that they were curious as to what hospice is, right? But for most people, it's within hours or days. So it really comes down to if they're in an acute care hospital setting, usually it's just waiting for them to be discharged to go home. And then we start when they get home. For some folks, it's a matter of, well, they're still doing a couple of procedures, if you will. So we're waiting until they're ready to get hospice started. But for the most part, when we have a referral right away, we're talking to the family or patient.
Mm-hmm.
We're making inroads into what we need to do to get things started so it can happen in hours literally less than an hour if need be.
Yep. Now, a related question I have is, how do you determine which team members, such as nurses, social workers, chaplains, are assigned to each patient?
So that's part of the evaluation process. So it changes too, to be honest with you. So some people want to have, oftentimes, especially if they're coming out of an acute care setting, their
Hmm.
biggest concern is the nurse
Hmm.
because they're really worried about how to do things. Um, so everybody has an RN or in case manager, we call them. We also have folks called hospice aides, another one to come out to help with personal care, so that with bathing and things like that. And we have medical social workers who are there to help the patient and family through community resources, through communication, through talking about things. We have chaplains who, like the social workers, are there for everybody.
Hmm.
We have volunteers who can come out and visit with people as well. And we have a very robust bereavement program after the person passes for at least a year and a month afterwards. So
Hmm.
what do people take? Well, people use all of the different disciplines that are available to them. And we
Yeah.
don't force it on them. It's what do they want? And
Yeah.
we try to encourage when we think that something may help, we try to encourage "Hey, this person may be able to help you or this role may be able to make a difference in your life.
Yeah. So, from my knowledge, how often do nurses come to visit a patient, during hospice? Is it only when the patient asks to be seen, or is there a routine where a nurse comes in every so many days?
So it depends on the patient's needs. This is one of those questions that is really important to understand. For some people, it's a visit every, one a week. For some
Yeah.
people, it's every day.
Yeah.
It changes on people's needs. Kind of what I tell people is the less you see the hospice nurse, the better,
Hmm.
right? Because that means things are going well. But the hospice nurses are always available 24 hours a day, 7 days a week. So when there's a change in condition or a crisis, you forget what to do, somebody's panicking, whatever, they call us.
Yeah.
And sometimes a call to us is a reminder, okay, we talked about this yesterday, walking back through what needs to be done. Sometimes it's a situation of, it doesn't sound real good, we need to send a nurse out. And sometimes it's both, which
Yeah.
is, hey, that doesn't sound good, we're going to send a nurse out. In the meantime, take this medication.
Yeah.
So this is where planning ahead of time, having medications in place ahead of time, we're able to get the symptom back under control as quickly as is possible. So we
Yeah.
don't want to have a big delay in people getting the care that they need, where they're waiting. What do we do? Then they call 911 and then they end up in the emergency department where they're starting at the beginning. And if you've ever been in an emergency department, you sit there for a long time. So we want to be rid of that world and rather get the symptom back under control as quickly as is humanly possible. So to answer your question that you really asked is how often is a nurse there? It
Yeah.
depends. So typically it's anywhere between 1 to 3 times a week, but that's really hard to tell because some people it's every day. Sometimes the minimum is once every 14 days.
Yep.
So it really depends on what somebody needs.
Okay. Thank you for that. Now, how does Sutter ensure quality and consistency of care across such a large and diverse region? Because Sutter is so big.
We are big. We're huge. So we are, SAP certified, and that's very important. We are very much involved in working on, we have metrics that we make sure SHP is a survey
Okay.
that our patients go through, where we know what we're doing. We make sure that our visits in the last days of life are very high. So we're looking at like 70% is what we're looking for. We really want to focus on what do we need to do to make sure that that individual's needs are being met. We have a very robust quality program here who are
Yeah.
very, very actively involved in every program. And we want to make sure that we're meeting our patients' needs and exceeding what the industry standards are.
Okay. Now, can you explain the medical criteria for hospice?
The number one thing is that somebody has to have an expectation that they're in the last 6 months of life.
Okay.
I mean, that's always number one. So when we start going through anything, does it look like they're in the last 6 months of life? And every disease has different indicators that tell us that somebody's in the last 6 months of life. And they're not all the same because they're all going to present differently.
Right.
Typically, what we're looking at is what I always tell people is, would you be surprised if they wouldn't be here for the next major holiday that's 6 months away from now? Because oftentimes from a family standpoint, they can see that. Are you seeing somebody who maybe is, not as active as they used to be, or they've lost 10% of their body weight, or they are withdrawn more, not communicating the same as they used to be? Those are indicators of recurrent infections, recurrent hospitalizations. Those are all indicators, but truly every disease has got its reason why you qualify for hospice. Sometimes we're wrong.
Okay.
Right. So sometimes people live longer than 6 months, sometimes quite a bit longer. Some people even graduate off of hospice.
Okay. So somebody could graduate out of hospice and then even come back later on. Is that correct?
Yeah, that happens frequently. Yeah, that
Okay.
happens frequently. So it looks like you're in that last window. You weren't, right? You graduate, then a period of time comes by, and the decline continues, and then you come back onto hospice. So that's not uncommon at all. And that's one of the things that we talk about with people is it looks like they no longer meet the Medicare guidelines for hospice.
Yep.
We have these conversations with them, but they're not eligible for hospice. We're not going to keep them on, and we can't keep them on. But if they are eligible, then we will either keep them on or bring them back on when they are. So it's not something that it's Medicare rules, and we very much have to follow them.
Okay. Makes sense. Now, what are the most common misunderstandings families have when they first call in?
You already touched on one of them. Is it a place? No, it's a philosophy of care. Other things are they think that hospice will shorten life.
Mm.
And that's really a sad thing because some studies show that hospice actually can lengthen life in certain circumstances. Would they think that we're going to be there 24/7? Yeah, that's one of the other big ones.
Yeah.
They think that they'd have to give up all other care.
Mm.
But those are really the biggest ones that we see. They also sometimes think that they can't do anything or go anywhere, that they have to stay home.
Okay.
I remember one time we had this gentleman who his wife had been on hospice previously, actually in another state. And she had really been only on for like a day or two because she came on really at the end of life. And he saw her go through a lot of interventions and really suffered, and he did not want to be that person. So when he found out that he had potentially terminal cancer, he decided not to have any treatment at all. He signed up for hospice as soon as he possibly could, and he was never home. I remember getting a phone call from him one day saying he was out of oxygen. And I said, oh, yeah, I'm not surprised because we couldn't get any to you. And I said, all right, we'll get it delivered. He said, well, I'm in Reno. And I said, well, we're happy you're in Reno, but let us know so we can coordinate your care. But you love those stories that people are actually living.
Yeah. Yeah. Now, what documentation or planning should families have before a hospice intake?
This is an interesting question to me. There's nothing that you have to have per se,
Okay.
but there's things that you should have. So if you have a durable power of attorney for healthcare,
Okay.
that's very important to have. If the patient is not able to make their own decisions, we need that documentation telling us who is the person who can make their medical decisions on their behalf.
Okay.
Or if that patient along the line of their journey loses the capacity to make decisions, who is the person who's going to make those decisions on their behalf? And oh, by the way, what is it that they want done and don't want done, right? So those are guidelines that tell people what it is that they do or do not want done. And the other one that's super important, though, is the pulsed. And that's physician orders for life-sustaining treatment. For those who haven't seen it, it's a bright pink piece of paper. And it's the biggest part of it is a do not resuscitate order. So patients do not have to have a do not resuscitate order to be on hospice. Most of them do. And if you do not want to be resuscitated, that needs to be readily available. It needs to be signed by the patient or the responsible party, but it also needs to be signed by a physician.
Okay.
So it's not something that can be obtained in an emergent situation. It's something that needs to be in place ahead of time.
Very good. Very good. Here's an important question. Let's talk about how the cost of hospice or how people are paying for it. What does Medicare or insurance typically cover, and what should families expect to pay out of pocket, if anything?
Most hospice patients are Medicare patients. So for most of the people who are on hospice, Medicare covers all of their hospice care.
Okay.
And that includes all of the services that hospice provides. That includes medications related to why they're on hospice.
Mm-hmm.
That includes durable medical equipment
Mm-hmm.
related to their hospice diagnosis. So typically that would mean a hospital bed, oxygen, a wheelchair, a bedside commode, overbed table, things of that type. It also includes supplies related to hospice.
Mm-hmm.
So it could be wipes. There's a lot of different things that could be
Okay.
ointments, things along those lines, disposables.
Okay.
It does not, I'm sorry, it does not, for folks who live in long-term care facilities, it does not cover their stay at the nursing home or an assisted living facility. And that's a very important component of all of this. People think that Medicare pays for 100 days in a skilled nursing facility. That's true in a way, but it's not true in a way also.
Mm-hmm.
And what I mean by that is if a patient has a skilled need,
Mm-hmm.
Medicare will pay for it for a maximum of 100 days, but it never pays for custodial level of care. So
Understood.
while you're on hospice from a skilled nursing facility, that is considered custodial from their standpoint. So the patient may have Medi-Cal or Medicaid.
Mm-hmm.
They could have long-term care insurance, or they are paying their own stay at the long-term care facility.
Mm-hmm. What are some red flags that might signal a hospice provider is not the right fit?
For the patient and family, the red flags.
Yeah.
The biggest thing is, are they listening to you? Right? And does it feel right?
Right.
Right. So the feel right one is really important because, like a lot of things in life, kind of that gut feeling
Yeah.
needs to be there. One of the things, though, I would caution people, because I do think it's important. Monday, you didn't feel well. Tuesday, you're hospitalized. Wednesday, you're going home on hospice. We see these
Right.
patients frequently. So does it not feel well? Well, it may not feel well because you haven't adjusted to what's happening.
Yeah.
So is it the situation that doesn't feel well, or is it that the hospice that doesn't feel well? But this is something that the hospice should be talking about themselves as well, that their patients are in these situations. So it's very important then that we are understanding where they're coming from. So if the hospice doesn't listen to you or it doesn't feel like they're understanding what you are, that to me would be a red flag. If they're not there when you need them, that would be a red flag.
Yeah. How does Sutter's not-for-profit status influence the way you deliver care?
We are, as a not-for-profit hospice, we're really about investing in our community. So
Mhm.
our stakeholders are not some finance company or investors. It's really our patients and families and our community at large.
Yeah.
And so we do a really good job of investing back into our community. And it's locally with our local hospice. We have this bereavement program that is just very robust.
Mhm.
And it's not just for our patients, it's for the community at large. And when I look at what we do and the different types of programs that we have and the lives that we touch, it's mind-boggling to me because that's something that we think is very important. Also, we talked earlier about taking on complicated cases. We take on complicated cases that are expensive, to be honest with you, that other folks aren't willing to touch. So ultimately, we're professionals in this organization. You talked earlier about myths.
Yeah.
One myth I used to hear from people was that they thought because we were not-for-profit that we all were volunteers working. Well, no, that's not true. We're all healthcare professionals. So everybody gets reimbursed the same. It's what do you do with that reimbursement? Who are the stakeholders who are benefiting from it? And to us, it should be the patient, families, the community at large.
Mm-hmm. Why do you think so many families wait until the very end to enroll in hospice?
That's a really hard one.
Mhm.
And it's something that we talk about a lot. And for a lot of people, it's denial.
Mm-hmm.
It's nobody has given them hospice as an option.
Hmm.
And they may have said hospice, but it may have been like hospice, as opposed to understanding what it really means. And a lot of people think that hospice is, the end, period. And they think that it is that last day or two of life. People don't understand. No, we're there to help you live until you do die.
Hmm.
People don't understand that. So it's holding out hope. It's, there's always another treatment option that's available. And so let's explore that. Let's explore that. Let's explore that. So part of it too is we're human beings and we don't want to let go, all of us at different levels. And so what I have found is the people who are really looking at life from a big picture, if you will, about and understanding where they are in the continuum, those are the ones typically get onto hospice near the 6-month mark. Those are the ones typically who really embrace it. Those are the ones who were able to get involved and help them live and help them build bridges that they've maybe burned, if you will. That's part of it. It's helping them get to a point where their pain is under control and their symptoms are under control, because hospice is very much a specialty in the healthcare arena. So we're able to get the symptoms under control and help them live and do what they want to do. So why do people wait? Typically, it's because the option hasn't been a realistic option for them.
Got it. Now, in your experience, how does early enrollment in hospice change the patient and family experience?
I talked earlier about the person who on Monday didn't feel well, Tuesday hospitalized, Wednesday coming home on hospice, right?
Right.
So when you look at that person, when they're coming home on Wednesday, they're scared, they're apprehensive, they're not trusting,
Right.
right? Sometimes they're really mad at the hospital that they were discharged. They're mad at their doctor that they couldn't fix them. They're mad at the world, understandably, right?
Yeah.
Things have happened so fast and they're scared and they don't know what's going on. If that individual is coming on early on, we're able to work with them and build trust. And trust is a big part of it. And we're able to get in there and develop relationships with them. And that is really big. I was talking with one of our hospice aides recently who's been with us for like 30 years. She just retired.
Yeah.
And she's amazing, amazing lady. And she was sharing with me stories that she had with her patients that I'd never had heard of before. And the love that comes from people providing that intimate level of care is absolutely amazing. And the connections that she would be able to have with her patients and by proxy with their loved ones is absolutely amazing. So when you're able to get in there early and you're able to build the trust and develop human relationships, right? And then look at getting the treatment that's appropriate for you at this point in your life.
Yeah.
Right? Too many people, they've been sick for a number of years. They've had a lot of medications, interventions thrown at them over this period of time. And we want to get involved, earn trust with the patient and family, and start looking at some of these medications. Is this an appropriate medication today? It may have been last month or last year. Is it today?
Yeah.
Right? Because we know it's got a side effect. And if it doesn't, if you're not receiving the therapeutic benefit from it, is it something that you really want to continue? For some people, yes, it is. Some people, no, it's not. And part of that, though, is the longer that hospice is involved, the more we can build the trust and understand and really look at the person's bigger picture about what's appropriate. And that's one of the greatest ways that we're able to get involved and have a big impact in their life.
Nice. Do you think hospice is still seen as giving up? And how can we shift that mindset?
Hey, that's a tough question. That's a really tough question. For a lot of people, they do see it's giving up, to be honest with you. And for a lot of people, they don't. They see it as part of the continuum of care. So I know in the 25 years that I've been in hospice, it used to be very much, oh, you're just giving up, you're just giving them morphine and they're going to die. That was what people understood about it. Through the years, we see more patients who, because they've been exposed to it at different levels, who that has evolved to a certain extent, actually to a great extent in a lot of cases. But there are definitely people still who feel like it's giving up. And how do we change that? Is we continue to talk, is do things like this podcast.
Right.
It's important. The more that people are able to communicate about it, the easier that it is. It's not easy for people, for a lot of people anyway, to accept death. And what I have found is typically it's actually harder for the families than it is for the patient. The patient's living it. They feel it. The family is sitting there and is vulnerable to what's going on between the patient's body and the disease process. And they want to fix it. They're not living it to the same extent. So how do we go about it? Communication is the biggest thing. Understanding that we're just a part of the continuum of care is a big part of it. And then to repeat the stories over and over and over that we're there to help.
Yeah. Can you share an example of a family that benefited from getting started early?
Oh boy, there's been so many. You know, one that really comes to mind, and it's a little bit of a twist on your question, so please forgive me.
That's okay.
I remember years ago, there was this lady who, it was a Tuesday,
Mhm.
and she was in a skilled nursing facility short term.
Okay.
She was there for rehab, and she was going to be going home on hospice on Thursday, which happened to be her birthday.
Okay.
And I was meeting, just the two of us were meeting, and she said to me, I just want to go home for my birthday. I said, yeah, we've got it planned. We got it for you. Don't worry about it. And she said, I'm not afraid of dying. She said, I've actually written some papers about end of life or the spiritual aspects of end of life, and I'm not afraid of it. She said, but my studies have showed to me that people usually can tell when they're near the end. What happens if I'm not? And so I said, well, you graduate then. And she said, do people really graduate? And I explained to her, yeah. And she asked for a story. So I told her a couple of different stories of people who had graduated. And she said, well, when I graduate, we're going to sit down together and write a book. And I said, okay, perfect. So a month or two goes by, and I get a note from the nurse that states, I feel it now. I felt it all along, but I was looking for something that was in front of my face and didn't recognize it. She said, so I really appreciate that opportunity that we had that conversation because it gave me the chance to reflect on what I am seeing. And then she signed it and thank you. So the benefit comes from over the period of time that we talked about earlier of people trusting, understanding, reflecting, us building trust in relationships.
Yeah. I want to segue now into tools and resources. What educational tools or resources does Sutter provide families navigating hospice for the first time?
We have patient handbooks that we give our patients.
Okay.
Those are very important because it's something we're talking about a lot, is making sure that we're utilizing those. When a patient first comes onto hospice, they're given a lot of information, too much information, right? As we all know.
Yeah.
And with anything, we're always given too much information. You get a packet of stuff, you tuck it away, you put it on a table somewhere. So our team is very much involved in making sure that they review that information with our patients and families because it's very important for them to understand what to expect, how to reach us. When we first have contact with a patient and family, we start talking to them about what to expect and how to reach us, because that's ultimately what is going to be the most important. We have sheets that we provide them that's disease specific, that we go over, that we mark up constantly. We're writing notes on that. We're helping them to understand what it is. So a big part of it is, all people are different types of learners, and we know that. And so we try to go through and find out what is the most effective way that this individual is going to get the message. So it's having conversations, it's having leave behinds, it's having, writing on things, but making sure first and foremost, when they forget something, they know they can reach us and we will be there for them.
Yeah. Excellent. Now, how do you support family caregivers who may be overwhelmed or unsure of their role?
Yeah, that's a hard one because people are overwhelmed, right? I mean, there's no doubt. You talk at the beginning of this, I know this is all about sandwich generation, right? And a part of that, I'm with you.
Yeah.
And, I like sandwiches, but I don't now. But, being overwhelmed is huge. It's a part of it. And so what we try to do, and a big part of it is if we can build the trust, that right
Yeah.
away takes away a lot of the stress that people have.
Okay.
We talked earlier about that early, coming on hospice earlier. That's part of it, is those opportunities to build trust. Another part of it is symptom management. If we
Okay.
can get that individual's symptoms under control, and that's what hospice does, right?
Okay.
That's what hospice is very much the expert, is managing the symptoms appropriately. And so if we can get symptoms under control, that decreases the stress a lot.
Hmm.
Having a team of people involved who are there to meet the physical needs, the emotional needs, the spiritual needs, the social needs, all of these are different needs that our patients and families have. And
Hmm.
so by getting in there and being able to manage all of these different things and working with them and offering community resources also that are available to them, it really helps a lot.
Hmm.
And to be honest with you, for a patient who lives at home, if they're having good old burnout,
Yeah.
we do provide respite care for our patients as well.
Oh, nice. Nice. And good relief. Yeah. Um,
Yeah.
yeah. Now, what's included in the hospice supply delivery, and how is that customized per patient?
Yeah. So the supply delivery goes back to, the durable medical equipment and wipes and pull-ups and, or briefs and, things like that. Everybody's got different needs. So it's really patient identified. So from the first contact, we start identifying what their needs are. So if they're coming out of the hospital to come home and they're on oxygen or they're bedbound, we're going to make sure that equipment is there before they get home, because they can't be sitting there without some of the important equipment. Otherwise, it's a matter of really identifying what their changing needs are. So on day one, a patient may not need oxygen, or they may not need a hospital bed, right? But they may down the line. And so we want to get things in place. I know with my mom, well, when she was on hospice, she did not want a hospital bed, period. And my mom
Okay.
was very stubborn. But we finally got the hospital bed in her room, but she never used it. But it was there if it was ever needed,
Yeah. Yeah.
right? And there's a lot of advantages to a hospital bed, right?
Yeah.
Um, So it's a matter of, what does somebody need and what do I anticipate? This is where the hospice team gets involved. We have an interdisciplinary team approach. And so everybody is giving their input as far as what this individual needs. If it's something that's important, like oxygen or a bed or wheelchair, we're going to have that there before the patient gets there. If it's something that changes as a patient's needs change, we're going to continually assess.
Okay. Yeah. You just mentioned the word team, and I know hospice work is emotionally intense. How do you and your team support each other behind the scenes?
I think the most important way to do it is we all need to be true to who we are.
Hmm.
I think that's very important. We need to reach out to one another and know that we're there. We have formalized things that we do. I've mentioned a number of times our incredible bereavement team. And, they are there to help really facilitate, along with our chaplains and our social workers, and
Yeah.
formalize programs for one another and reach out. And that really lays the foundation for what we need to do. And then just one of the things with hospice is you have people in hospice who are in hospice for a reason,
Yeah.
right? And so most people in hospice naturally understand it's time to reach out to somebody.
Yeah.
The problem is oftentimes we've built walls and we're not always willing to accept it.
Yeah.
But it's trying to talk through that ahead of time so that when you do need help, you are willing to accept it. And it's really being true to who we all are. I'm a kind of a goofball, if you will. And so to me, I really foster fun because I think that's really important. We see a lot of sadness. And so I really tap into that goofy part of who I am. And we try to have fun in the office and try to make sure that our clinicians who are out in the field can feel that as well. Because it's not always a sad, heavy thing. We're oftentimes, are clinicians out there and they're celebrating life with people. They're going to
Yeah.
the person's 103rd birthday party. They're celebrating the person who's graduating off of hospice, or they've reconnected with an old friend or a loved one who they haven't talked to in a long time. There's a lot of uplifting things that happen in what we do. It's you're out at the grocery store and someone comes up behind you and hugs you.
Yeah.
It's sharing those stories with each other, because we all have a lot of them, and that's how we are there to support each other.
Yeah. Now I know because of your 25-year tenure, you have hundreds and hundreds of stories, but what's one story or a patient encounter that continues to shape how you do this work?
We had a gentleman who had been referred to another hospice,
Okay.
and he was a veteran, and the other hospice had gone out to meet him and sign him up for hospice, and he kicked them out of the house.
Okay.
Where they got started. He was tough. He had been a very powerful man in the military and also in business world.
Mm-hmm.
And he was also a big softie. He had 3 daughters and a wife who just ran all over him. But he would never know that. I walked in there because I was asked to, and they asked me to do it because they thought that I would be able to connect with this gentleman.
Okay.
And I walked in there and he kind of just read me the riot act. Why are you here? I don't need this.
Yeah.
All of this. He said, hey, let me do my job. And
Yeah.
he appreciated the fact that I was kind of humble and just said, let me do my job. And so we went in there, we had a conversation, and we very much connected. Yeah. And he shared with me some stories that were very, very powerful that his family hadn't heard before. That really drove me to understand that in hospice, we're there to make a connection to people,
Mm-hmm.
that we're there to help people. And as I go through different things during the day, and I start questioning, why are we doing this or why aren't we doing that? And people are asking for different things and cases are frustrating at times. I go back to cases like his, where I know that by listening and providing the appropriate care and then having that evolve over time, that we're able to make a difference in somebody's life. And to me, what's really important is being that difference.
I love it. Thank you for sharing that. My last and final question is, if a family is listening right now and feeling uncertain about the road ahead, what's one thing you hope they take away from today's episode?
You're not alone. Period. You are not alone. This is a very challenging time.
Yeah.
I had a patient explain to me one time, she happened to be a cancer patient,
Mm-hmm.
and she shared with me as I was explaining hospice to her, she said, okay, I think I understand what you're saying to me now. She said, my primary doctor said he couldn't do anything for me. I had to go see a specialist. And then the cancer doctor said I needed to go see an oncologist.
Mm-hmm.
Yeah. And then my oncologist told me I needed to go see another specialist now. And she said, that's you. And I said, yeah, you're right. Everybody in the healthcare arena has an area of specialty. And hospice happens to be the specialist at care at this point in somebody's life. Mm-hmm. And so when you're coming onto hospice, it's not about taking away. It's not about stopping. It's about what do we need to do to help you live the best today, plan for tomorrow, and then do what you need to do. And we are there to help support you through that journey. We're there to help you make choices, hard choices. And the beautiful thing is that when we're helping you make these hard choices, not only is it a team of experts in the industry, but we're also seeing you where you live and helping you make decisions where you live. We're not doing it in a clinical, sterile setting.
Mm-hmm.
We're doing it where you live. We're helping you live the best that you can. You've got people there supporting you throughout this journey. Would really be my takeaway.
Amazing. Jerry, thank you so much for sharing your deep expertise and giving us such a thoughtful behind the scenes look at what hospice really is and how families can navigate it with more clarity and confidence. You've helped break down so many misconceptions, and I know this conversation will help a lot of people make better informed decisions. And for those of you watching or listening, and if your loved one is considering senior living and you need to figure out what to do with their home, let's talk. Schedule a free consultation with me by clicking on the Calendly link in the video or podcast description box. Learn more about my services at www.simplifyseniortransitions.com. DM me anytime at Sold by Dale on Instagram. And if you found this episode helpful, please leave a 5-star review on Apple Podcasts or Spotify. It really helps more families find the show. And don't forget to share this episode with someone who needs it. Thanks again for joining us. Jerry, one last thank you for being on the episode today.
Thank you very much.
You're welcome. And for everyone else, I'll see you on the next episode of the Simplify Senior Transitions podcast.